Good morning, everybody. Can you hear me? Is it on? Yes. Thank you for inviting me, and thank you for being the first speaker, as I have to go back later on. But I have a good group of respiratory physicians and researchers who can answer all the questions during those 3 days. I'm going to speak about respiratory complication in elite athletes, and I will also touch about something about doping. I have some disclosures, as some of the doping is within the pharmaceutical companies' interests. Why do we develop asthma? There is genes, of course, which is involved in the development of asthma. There's some environmental things. And we also know that the diet is important. We know that the systemic inflammation is increasing substantially after you have eaten a McDonald's burger. And increased systemic inflammation is the same as increasing inflammation in the organs. And inflammation is part of the asthma disease. And we know if you reduce in the obese, if you reduce the number of McDonald's burgers, you will reduce the asthma severity. You will have better asthma control. We don't know whether lean persons, if they go into new Nordic diet, whether they will have more asthma control due to the high protein and low sugar. But we certainly know that obese, if they start doing exercise, they will be more controlling their asthma better. So there is something about asthma and the way we are living. On the other hand, we also know that too much exercise might be a danger to your respiratory system. And the reason why we know that is we have investigated the asthma frequency in elite athletes for a number of years. And if you take this one, that is a group we did a normal public study many years ago when I was a young researcher. And the frequency of asthma in the Danish population is around 5, 6, 7%. But if you look at the swimmers, the elite swimmers, independent of whether it's male ones or female ones, you have an asthma frequency which is about 30%. And we tested all the Olympic going to the Beijing Olympic Games. And the average, or the number of asthma in the Olympic group was 30. So there is a high frequency of asthma among the elite athletes. Now, if you look at Denmark, the asthma frequency is high because what we are good at is swimming, rowing, and whatever. And that's why it is a high frequency. But independent on that, many elite athletes develop asthma, and it is higher than the normal population. And this is just young ones. They're 15 years, young swimmers, when they start doing their their exercise, and they go from junior to not senior, but the level in between. They start having lots of training, and they have more asthma. And it's not something they have because we always will say that small kids which is having asthma should swim because it's good. And when we look at these 15 years old, which is elite swimmers, they did not have asthma when they were kids. So it's something you gain, it's not something you have. There's a difference between having asthma and asthma symptoms. This is the asthma frequency in the elite athletes, and that's their complaint of respiratory symptoms. And it is the same in the general population. They might have lots of asthma symptoms, but they do not have asthma as such. Asthma need a positive asthma test to say that they have viable airway disease. We have tested a large group of elite athletes. Here you have the elites. They are 19 here with asthma and 35 with non-asthma. And you can see the frequency of complaint is 69% is complaining about respiratory symptoms, and 95 of those with asthma is complaining. it is similar figure, but less in the ordinary group. So you need objective measurements to say that it's asthma and not just coughing and sputum and things. Because of that, a group was set down in just before Beijing, and you cannot see it, but I'm actually there in the back. And we decided that you need to have positive asthma tests to become asthma patient. And of course it is like that. That is in clinical setting. We would never make an asthma diagnosis in specialist setting. Of course you do it in GP setting. But in specialist setting, we would never do it without a positive asthma test. But in elite atlas, it's different. Because Africa and Asia and Colombia, whatever, should be similar set out. But we decided that you need to have the positive tests which is showing that you have a viable disease. One thing, if you know anything about asthma and respiratory diseases, is that we said that peak flow monitoring morning and evening was not a good cutoff for asthma in elite athletes, because they are bright, they are brainy. They know if you should be viable with 100 up and down, they can certainly put it down with a pen and a paper. So that was not it, you had to have a test. And these numbers are before the cutoff of asthma test was performed, but what you can see is that the asthma frequency is below 10, and it's increasing substantially towards the Athens Olympic game, and the Sydney was in 2000. And after that, it has been very, very difficult to gain the actual number of asthma patients or asthma elite athletes. There's no substantial numbers where you can go in and say, this frequency is it. But there's a paper concerning the beta-2 agonist use, and it has decreased a bit after the testing has been a limit. And you can see here, there's a difference between these asthma patients. Some sports will develop asthma, and some will not. Shooting, wrestling, whatever, have a low frequency of asthma, whereas these cycling, triathlon, swimming, rowing, canoeing, all develop asthma. And it is a thing we will see because it is in endurance sport. If you exercise a lot, if you have a high number of hours where you train, you have a very, very hard breathing in and out, and you do it within a short period. We think you spoil you damage your airways in that way, and because of that you develop something which we will call asthma. There's only one paper, very old one, from Finland, where they have examined the elite athletes after they have stopped, and they say that it is less asthma in those who have stopped than in those who still is doing their elite training, saying that it is something you gain when you train and you lose when you stop training. And you can say asthma is a chronic disease, so you shouldn't lose it. But it seems as you might lose it, or you are just not examining the right things. But we hope to do that, because we have been examining sports people for many, many years, so we can follow up a large group of sports, not a small group of swimmers. Yeah. This is my favorite slide. It's made by one of the best physiologists from Sydney. She's called Sandy Anderson, and she knows a lot about asthma. And if you sit there and think about what is asthma, what is going on in the airways, this is what is going on. You start breathing, and you breathe in and out, and you get short of breath, and your dehydration of the airway surface starts. When it starts, the increase of the sodium, potassium, and all the things there increase, and you have increased osmolarity. The water moves from these cells to restore the environment around in the airway surface, and when it does that, the cell shrinks. They need to have their round size to keep out shrinking and spoiling and delivering mediators. And that is what is happening. The mediators is released, and the smooth muscles are contracted, and the exercise-induced bronchoconstriction is happening. That's how asthma when you do exercise happens. And it is not only in sports people that is happening. 80% of all asthmatics is having exercise-induced asthma. So don't think exercise-induced asthma as a sports thing. It's a general thing. This is you and I in here, those who is not having asthma. We heat, the heat loss, the airway cooling, the secretion, the coughing, the shortness of breath, and all the symptoms. We do have the symptoms, but we don't have the bronchoconstriction because we do not have the cells. The cells are needed to have this. This is more in the allergic area where you have the same. And over here we have a group which is having hyperresponsiveness to non-specific agents. And that's in general some of the sports people, they will have that one. So what you need to have the asthma symptoms with bronchoconstriction is the inflammatory cells with the mediators who can be released, and when it does that, you have the constriction. If you are not having the cells, you are not having the constriction. But you can have the symptoms. You get short of breath when you're running. And this is one of our rowers. He was in the heavy 4 boat thing. I don't know what it's called. And he was, you can see, high and weighed a lot. And when he was doing the exercise, he was actually reducing his lung function with 50%. We have a test which is called eucapnic hyperventilation test. And that one, you stand hyperventilate for 6 minutes like this. And your airway get very dry, and the cells release their mediators. And he is having asthma. He's not just having symptoms. He's not just noisy with wheezy. He's actually having a bronchoconstriction with a low FEV1 afterwards. His lung function is reducing. This is an ordinary exercise test where you exercise for either 6, 7, or 8 minutes. When you are a kid, it's 6. If you are young, it's 7. If it's an adult which is tested on exercise, you need 8 minutes. And that's because adults need to, they start like running a bit, but they don't get short of breath until a little while, and that's why it's 8 minutes. And when they stop after 8 minutes, the lung function will start decreasing because they are dry in their airways and they will release their mediators. A very interesting thing is that if you have an exercise test here and you have a reduction from 70% to 40% in lung function, which is 30% reduction, and you let them keep, get good by themselves, increase their lung function, you get back and do the second test. And what you can see is that the second test is less severe and the third test is less severe. And that is something the asthma patients and all our elite athletes know. If they do the workout before they do the testing, they're better off when they do the testing because they have released all the mediators and they're not having any more mediators. The difficult thing about the elite athletes is that they are not responsive to everything. Most asthma patients is responsive to everything, but you can see that some will be responsive to EVH, some will be for exercise, some will be for lab testing, and some will be for methacholine. But independent of that, 62% is hyper-responsive between the elite athletes compared to 16% of the Danish population. So they are highly hyper-responsive. And some of them is having the asthma disease and some is actually not. And here is from the real life. We tested 102 sports people in the real life setting. And you can see this, the red one is when they have test positive. And we need to test them with different kind of tests set up to be sure that they are either not asthmatic and just symptomatic or they have asthma. we normally would have like 2 tests before we have the actual diagnosis. Yeah. The surface of the bronchial epithelium is different when you have asthma compared to when you're just as sports people and normal. And you can see on this one that if you're in sport and you have hyperresponsiveness, you're more similar to ordinary asthma patients if you look at the thickness of the basal membrane than if you just have symptoms asthma but not hyperresponsiveness. So it seems as the bronchial hyperresponsiveness in sports people and in asthmatics make them very similar. So now you know what an asthma patient is, and you know how their hyperresponsiveness is just different from ordinary asthma patients, but the mechanism behind it is absolutely the same as in ordinary asthma patients. How do we treat them? Here I have just a single patient, and I know it's just a case, but it's just to tell you how I work in my daily life. We test him with EVH, and he is a sprinter. After 1 minute, after he has been hyperventilating for 6 minutes, he is reduced by 29%. After 5 minutes, it's 57%, and 10 minutes, it's 52%. The test is made that you should stay like that for 20 minutes, so we do that. And we just look at them. They are short of breath here, I can tell you. Then we treat them with ordinary asthma medication, and 1 puff twice a day would be enough for an ordinary patient. And we test them again, and you can see 15 is better than 29, and 17 is better than almost 60, and 7 is better. So he got better, and he's not having it for so long time. But it's still not good enough, because the sprinter, he wants to win. If it was an ordinary patient, he would say that he was better off and he could bike. So what I did was I increased his dosage, and now you can see he's very satisfied and he's well treated. Just to say to you that ordinary people might need lower dosage than sports people, and it has something to do with the biology in their airways. It has something to do with the inflammation being more over in the neutrophilic and the macrophages compared to the eosinophilic inflammation. Similar to the other study, you can see that the percentage of treatment in the endurance sport is the highest compared to the other ones. And here you have the guy with the 50% decrease. And when they were there, he was very noisy. They were all very noisy, very wheezy. And before treatment, they had like 10 or 12 positions or places when they were doing competition. And when he was well treated, that one, he was very noisy as well. And I had him in to test, and he was asthmatic as well. So he was treated as well. And the 2 other came because they were noisy, but they did not have asthma. So 50% in this boat did have asthma and were well treated. And after that, they gained first positions, 4 positions, and 3rd positions. So either they are well treated or it is doping, what I'm doing in the clinical work. I think it's well treated, but you could say that it could be something else. And why do I say that? I say that because in 2012, there's a publication by Ken Fitch from Australia. And he looked at the number of swimmers in the Beijing or London, 12, so that would have to be Beijing for publication, standing here, sorry. Beijing, 19% had asthma, but those 19% gained 32% of the medals. And they were asthmatics and treated, and if you have the same here in the cycling. So what we are talking about is that the amount of medals gained by those who are having asthma is higher than those who are not having asthma in the same in the same sport. Is it doping or is it not doping? And what is happening when they have their asthma medication? We have tested elite athletes and controls and asthmatics and control to see whether when they have 16 puffs of salbutamol, which is allowed amount, whether there is a difference in their pharmacokinetics, and there's not. It is similar when they have the elite and the control. They're peeing out the same amount of beta-2 agonist, and when it's asthmatic and controls, they're still peeing out the same amount of beta-2 agonists. So it's not that the elite athletes are gaining it and having it in a different way. It's coming out the same in the same manner. The discussion in doping is whether it's taken by inhalation or it's taken by oral. And if you look at this, this is inhalation and this is oral intake of beta-2 agonist. And what you can see is that there's no difference. It's just a little bit later if you take it as oral intake. And now we are getting closer to the doping thing. He's a doping case, and he was caught by, with beta-2 agonists. And to continue there, there's a lots of known people who is having asthma. And this is the number of studies with therapeutic inhalation and the effect of the beta-2 agonist. And as you can see, there's very few where there is a number here. Otherwise, it's no effect. So it has been very difficult to show what is happening. Why are they gaining more metals? These are negative or positive by therapeutic inhalations. And you can see there's a couple of. Firstly, what you would think is that the oxygen uptake would be better if you have beta-2 agonist, because it is in endurance sport. This is 47 puffs of beta-2 agonist, huge dosage. No change. We have another one, which is oxygen uptake after beta-2 agonist. This is at screening, this is at endpoint, and that's 2 weeks of inhalation. So neither acute intake of beta-2 agonist or long-term intake of beta-2 agonist changed the oxygen uptake in these asthma patients. Oh, sorry, this is normal. In normal persons who is having oxygen uptake taken. So little evidence that suggests that beta-2 agonist is performing enhancing in healthy non-asthmatic subjects. But what about if you give it in higher dosage or in systemic? And here you have a better flow. There's more who is having support for that it is doping. The hypothesis in the next study is that more elite athletes are gaining better victories, and it could be something about the power and the recovery. And we have looked at that in our lab. And here you have the terbutaline increased the peak and the mean power. You have the placebo, and you have the terbutaline, and this is the peak power, and you have the mean power as well. That changed with the Wingate setup. And this is the lactate, where the beta-2 agonist is showing a higher curve than the placebo is having. We also tested formoterol, which is a long-lasting beta-2 agonist towards and the short-acting. And you can see both of them is showing that power is better in the two groups. It is statistically significant, although there is a very small difference. We looked at the energy consumption, and you can see this is placebo, terbutaline, placebo, formoterol, and there is a class effect, which means that both the formoterol and the short-acting terbutaline is both having a different glucoside than the other ones. So it seems that the muscles are performing differently when you take the drug. The power is tested with the baseline, acute, and after 14 days. And here you have the muscle power here in that one. But it's not the same independent on which, when you do placebo, you have the same level of power. Recovery were tested, and you can see when you have beta-2 agonist and you have had it for 2 weeks, it is better there compared to the placebo. So it seems as when you test for the power and recovery, it changes. We also have them in the swimming pool with the arm swimming, 200 meters. And here's the force, independent on whether you have hyperresponsiveness or not, is higher when you take beta-2 agonist. And the tricky thing here is that you are taking therapeutic dosage of 4 different kinds of beta-2 agonists. So you will not be caught when you are paying for the testing. And the time to gain 200 meters is almost a second lower. So you swim faster when you have all 3 beta-2 agonists. Not all noisy things are asthma. We tested a large group of elite athletes. These are having positive asthma test. These are not having positive asthma test over here. They're having a test where they're running with a scope. They have a larynx disease and they are having lung disease. And the tricky thing here is that both of them will be treated with asthma medication. That one over here, asthma only, should be treated with asthma medication. That one down here, asthma and laryngeal disease, should be treated with asthma medication. That one over here should never have been treated with anything. And that one over here should never be treated with anything either. So there's a large group of elite athletes which is wheezy, have a laryngeal closure, which is treated with beta-2 agonist and inhaled steroids. So in conclusion, asthma symptoms and asthma disease are found among elite athletes. Not all wheezy is asthma. Many medals are gained by elite athletes who is taking asthma medication. Sparse documentation for therapeutic doses of beta-2 agonist or doping. Substantial documentation for high dosages of beta-2 agonist is doping. No change in oxygen uptake. Better power and recovery when you are on beta-2 agonist, and combo of several different beta-2 agonists are performing enhancing. And this is my group at the Bispebjerg Hospital. And here's Morten. You can ask for everything. Good. Thank you.